Thank you very much, Roxanne. If I could get my slide up. I don't really think I need to give this lecture. I think Dr. Sharma sort of proved the case for me. But, you know, both he and I have been doing coronary intervention for probably 30 or 40 years. And you get a feel for when you need this. It's kind of like pornography, you know, when you see it. And so high-risk cases really are very important to understand. The case that we saw this morning was high-risk, bad ventricle, severe left main lesion, need rotablator. And in the past, before support, you would dread these cases because you were walking on thin ice. Go through rapidly, do as little as possible, get the culprit artery fixed, and get the patient out of the cath lab. And it's doable. There's no question about that you can do these cases without support. But the complexity of these really require that you have more hemodynamic support. So what do you need if you're going to be in this game of doing hemodynamic support? You need to be able to do large bore access, 14 French femoral artery sheaths. You have to be able to know how to use dry closure techniques. You really have the repositioning sheath, etc. You need hemodynamic imaging, as we saw this morning. You can't really do these cases well without having optimal hemodynamic results. You need to be competent doing rotablator, orbital atherectomy, and laser, bifurcation, stenting, and then hemodynamic assessment and strategies to monitor these patients. And I think it's really crucial that you have all of those in your armamentarium if you're going to be able to get into this business. Well, you know, Holger is an absolute master at randomized trial, and he's done incredible work with this in cardiogenic shock. So I know that he's going to be getting some trial data. What is the trial data on patients with poor ventricular function, complex multivessel procedures? There's only one study. There was one in Europe that was done with a balloon pump, and there's only one in the United States that's been done, true prospective randomized trial. This is the PROTECT 2. This is the data that we have. This is what we have to live with. The patients were treated with high risk. They had 3-vessel disease with EF less than 30, or left main disease with EF less than 35%, just like the patient we saw this morning. And the patients were randomized 1-to-1. The primary endpoint was a composite at 30 days. We wanted to go 90 days. The FDA said no, the surgical results should be 30-day endpoint. But again, we as the people that designed the trial wanted to go 90 days. And so we did follow the patients for 90 days. And so we were able to get a composite endpoint at 90 days. First, without a doubt, Impella provides better hemodynamic support than balloon pump. We looked every 15 minutes during these cases to see if the patients became hypotensive, and the degree of hypotension was significantly greater in patients that had balloon pump compared to Impella. And it makes a difference how many vessels you're treated. On the left, you can see that the patients with balloon pumps are the 1-vessel disease, 2-vessel disease, and 3-vessel disease. The more vessels you treat, the more likely you are to get hypotensive during these coronary interventions. And that really does matter, because then the operators start to hurry, you're doing less complete revascularization, and the patients become impaired. With Impella, there was really no significant change whether 1, 2, or 3 vessels were treated. So this is the endpoint. And again, this is the data that we have. On the left, you can see the intention to treat 448 patients. And at 30 days, there really was no difference in event rates. And this is why the DSMB, when they took their first look, said that the study should be stopped on futility. But we knew that the results really were important. I want to point out to you that the original Hochman shock trial, the first New England Journal paper on cardiogenic shock, the results were negative. At 30 days, the results were the same. At 6 months and a year, then the mortality spade, and that's why we have a 1B indication for use of PTCA in cardiogenic shock. On the right side, the per protocol analysis, these are the patients that actually met the inclusion and exclusion criteria. It was significantly different. So this is the data. On per protocol, if you're using the devices correctly, you will have an improvement in events. The other thing about these event curves is that the things that happened to these patients after 30 days actually were very clinically significant. They either had to be rehospitalized for heart failure, they died, they had major adverse events. These were not just biochemical markers. So it's really important. It's not only an event curve, but meaningful data for the patients. And so when George Dangus looked at the analysis, again, when the original study was conducted, one of the adverse events was acute myocardial infarction. This was defined as a 3-fold increase in cardiac isoenzymes. When a more modern approach with an 8-fold increase, which is now what's being used, which is clinically significant, there is a 30% reduction in major adverse events with the Impella versus the intra-aortic balloon pump. This study was done in 2010 to 2012, so it's a decade old. There haven't been any other trials that have been done in this space. And the reason for that, it is very difficult to do these studies. The patients are extremely ill. Doctors don't want to randomize these patients, and it's been very difficult to sort of continue with this, but we are continuing. Again, the other important thing is if you're going to treat one vessel, it's really unlikely that you're going to have much of a benefit or much of a difference between balloon pump and Impella. However, if you treat 2 or more vessels, the results are significantly better with a significant reduction in adverse endpoints when the patients are treated with Impella. Now, again, if you look at this slide, this study was conducted between 2008 and 2010, and this is really just at the dawn of the use of hemodynamic support throughout the United States. But the use of Impella has started to increase, and now we have much more experience. So the procedure really was in the early infancy when the original PROTECT 2 study was done. We now have the PROTECT 3 study, which is a prospective FDA-mandated post-approval study with patients that have adjudicated endpoints. They have an independent clinical event committee, and we're looking at hard endpoints and comparing the PROTECT 3 versus the PROTECT 2, you can see that across the board, MACE is lower, rate of myocardial infarction is lower, repeat revascularization is lower. Very importantly, bleeding and vascular complications are significantly lower now, because when we did the original PROTECT 2 study, patients did not have ultrasound-guided access. There were no closure devices that were available, and we're largely using two puncture sites to use the Impella and do the coronary intervention. So with all of that, the procedures have gotten substantially better. Hemodynamic support with a 3.5 device is significantly better than with a 2.5 device, and the need for CPR and ventricular arrhythmias was also significantly reduced. So the American cardiologists have gotten better at using Impella in these high-risk procedures. It's safer, there's fewer bleeding events, and I think that the results really looked dramatic if we look over a long period of time with balloon pump on the left, the PROTECT 2 Impella with a 2.5, and now with the CP, the clinical events have gotten significantly better. And I think now that this whole procedure has gotten towards like a plateau in terms of efficacy, it is time to do a randomized trial. Greg Stone is the co-principal investigator with Stefan Windecker. This is now a large study, 1,200 patients that again meet the same kind of endpoint criteria that we talked about, are going to be treated with either Impella or control. Now, control can be nothing if you don't want it, or control can be intra-aortic balloon pump, or it could be ECMO. But it can't be Impella, and they're going to be randomized. The events are going to be looked at 1 month, 6 month, 12, 24, and 36. There'll be serial echoes, KCCQ, 6-minute walk, and the usual Dr. Stone multiple subgroup analysis. The hypothesis is that you'll be able to improve the patient's hemodynamic stability, you'll improve stent optimization, more complete revascularization, and this should result in an improvement in outcome. The primary endpoint is going to be all-cause death, MI, durable LVAD, or heart transplant within the first 3 years. So that's going to be the major endpoint, but the patients will be analyzed at these endpoints that I've talked about, and the last patient will be, the analysis will be done when the last patient has 1 year follow-up. There's going to be major sub-studies, right, heart cath, renal function, and viability. So I think that the data really is very strong for the use of mechanical circulatory support. We only have one randomized trial in the United States, which is the PROTECT 2. This is now a decade old, and the results have gotten substantially better. So if I was a betting man, I would predict that this study is going to be markedly positive. Thanks very much for your attention.